The title is Differential Diagnosis of MRI Markers of Cerebral Small Vessel Disease. Please, Frank-Erik.
Very challenging style. We also have a differential diagnosis of small vessel disease. If it looks like a jar, it swims like a duck, it walks like a duck. We all agree this looks like a duck. But now, it is located in a white matter. It's hyperintense on flare. Is it small vessel disease? You could probably divide it for me as being small vessel disease. If I now show you the schedule with this very same patient, you can know obviously not what we mean by small vessel disease. You see Dawson figures of the patient with MS. So this is what I would like to do with your presentation. Every white spot that you identify on MRI scan indicative of small vessel disease. Why is the proper classification of small vessel disease important? And I can briefly touch upon different vascular causes of small vessel disease. So just some examples. I think everybody will agree that this is not small vessel disease. This is Alexander disease, no doubt about, and no doubt based on seeing these MRI scans. But if we show you this scan of the other patient with the same disease, there may be some doubt what kind of leukodystrophy like disease you're talking about. Single scoop for the picture I just showed you before. Typical Dawson figures, no doubt about it. There can be no confusion that it's good or has small vessel disease. Let me show you this picture, also a patient of multiple sclerosis. You can serious doubt that this is also the small vessel disease neurovascular cause. A final example of the patient with primary anxiety. This is a combination of supporting and supporting parts. The left panel again, it's clear things with no confusion. There are also examples of this type of small vessel disease, very particular, like there can be some confusion that is quite perhaps small vessel disease rather than vascular. So I think this also indicates that proper classification is important, because it's not every white spot that is associated with disease. It's particularly small vessel disease that is the most important vascular contributors to dementia and to vascular Parkinson's. Small vessel disease, not every small MRI scan. That is a quarter, it's the cause of a quarter of ischemic stroke. It causes the majority of intracerebral hemorrhages. It's a fact that leads to that nursing homes exist in the rest of society. So we really need to make sure when we're talking about small vessel disease, we talk about every single white spot on an MRI scan. And the risk of misclassification obviously find a spurious relation between small vessel disease and the outcome. So proper diagnosis is important, and how do we properly diagnose small vessel disease? The answer always lies in pathology, and there's an idea that you have a brain on your plate of pathology. This is only a cell of the case, I only had it once. You can take a picture and you can perhaps dissect the vessels and see what's going on. Depend on the left, normal appearing blood vessels, and here you depend on the right vessels really affected by arteriolosclerosis. You're narrowing on the luminous because you don't flow possible anymore, so only by inflammation. This is, as said, only seldomly possible. So this is what, and I think Amico already alluded upon this as well. This is why pathology, so to say, was operationalized by defining MRI markers. So done by the STRIPE consortium in 2013 and 2023. Put in this paper together by Joanna and Marco and Martin. So maybe this answers a little bit Arne his questions apart from different etiological diseases like demyelination or leukodystrophy. There are obviously also different vascular causes of small vessel disease. Because as you can appreciate from this entire spectrum of small vessel disease, it's hard to believe that this is caused by one single disease, by one single vascular cause. It goes from the picture on the left, or the acute recent support of the Parkinson's, to the pictures on the right, to the hemorrhagic spectrum disease. So the leaky blood vessels versus occluded blood vessels. It's difficult to keep this due to one and the same disease. So I'd like now to focus when it comes to different vascular causes of small vessel disease, particularly the white and hypertension disease, and disentangle this by location and look at supported white matter hypertension is ventricular white matter hypertension and cortical microinfarction. And although it's not the highest level, the highest standard of research anymore, you can learn a lot by simply observing what's going on in your patient. I think this is a nice example of how you can learn something simply looking at repeated analysis of what's going on with your patients and potential mechanisms. So the top row reflects baseline imaging in a patient with quite severe cardiac hypertension, and the lower panel reflects follow-up imaging a couple of years later. You see reveals of isolated incidental support for hypertension with white arrows, and these seem to pop up more or less randomly in the white matter in an isolated fashion. Whereas you see here in the yellow and the red arrows, you see kind of a recruitment of initially normal appearing white matter into white matter. So by simply looking at it, there seem to be different mechanisms going on. And I'd also like to illustrate this with a case from the study that I'm already highlighted, part of the serial MRI scanning study with 54 individuals, all patients underwent MRI scanning 10 times over a year. And this is just a case of 70-year-old man with no symptom at all. And again, indicative of what's going on in this patient and potential mechanisms. This is just a series of MRI scans just made over the course of 14 weeks. The arrows indicate incidental both cortical microinfarction and cortical hypertension. So just over the course of 14 weeks, 3 months, this patient experienced so to say, a shower of white matter without any symptoms at all. Isolated focal white matter in the supportable areas or supportable areas. Over 10 of these in 3 months. And if you look at these images, if you look at the lesions, it's hard to believe that this is intrinsic small vessels. Obviously, can play a role. But others, Xu and Salma Hilal from Singapore, have shown that apart from already small vessel disease, arterial sclerosis, I just showed you as almost a specimen, also embolic sources play a role in these supportable pulmonary hypertension, this age population, but also intracranial stenosis, which is completely the other end of the spectrum of small vessels. The large arteries are getting stenosis and are playing a role in pathophysiology of these isolated supportable hypertension, as does, for example, hyperperfusion, for example, patients with heart failure. So now let's move on from the supportable white matter hypertension to periventricular white matter hypertension. And we can also already point the term periventricular penumbra, and I think it's nicely illustrated by this picture here. In yellow, you see areas of pre-existing white matter hypertension, periventricular capping, indicative of small vessel disease. And in the areas of green, you see areas of low structural integrity at the baseline scan that are about to convert to white matter hypertension 5 years later. And even surrounding those areas, the areas in blue are also already areas of the lower structural microintegrity that are about to convert 9 years later into white matter hypertension. So apparently there's an area surrounding the periventricular white matter hypertension that are gradually being included into the periventricular white matter hypertension, what we call a white matter penumbra. So what's going on in this area? So these slides are ordered from Gemma Guardia, also from Hanai, using pathology correlation study and post-mortem study, which identified controls and individuals with hypertension, periventricular white matter, as you can see here, and went to high field imaging of 12 Tesla and identified under release of white matter. MRI scan the underlying pathology and correlate with histopathology. In this example, she looked at activated microglia. On the left panel, you see controls. You see virtually no activated microglia. As you can see here in the area. Here, you can see no activated microglia. The more intense, the more red gets, the higher degree of activated microglia. For your orientation here, we have the MRI scan. So this is the ventricle, this is the periventricular area. And here in individuals with hypertension, with more periventricular hypertension, I think it's most outspoken here, you clearly see areas of activated microglia. And this is nicely, see similar findings in work previously done by Watson, by Marcus, who nicely showed also activated microglia in yellow, in part in the same region, particular areas, but also in many other areas, but also other physiological processes going on. As you heard before this afternoon, for example, in blood-brain barrier, you can see here indicated in green. Maybe surprisingly, and interestingly, those areas do not spatially overlap. So one and the same patient are different physiological processes going on. This is sort of still sectional work, so we have to wait and see how it is exposed to the development of small vessels in this area, either in yellow or in green, or perhaps in both. And finally, work from Matthijs Biesbroek, showed that, of course, the vascular risk factors are associated with periventricular hypertension. The frontal parts, as you can see in red, but the more posterior parts seem to be related with amyloid. The angle of the different pathophysiology by location. To summarize some of the pathophysiological features of periventricular hypertension, showing there's a loss of microstructural integrity, seems to be some inflammation going on, brain barrier leakage, amyloid play a role, and novel concerns that you often hear about are about hypertension and the infections. All together, they constitute a vulnerable area surrounding periventricular areas, periventricular penumbra. So remember, if it's black and white color, if it has 4 legs and it walks in a lush green Swiss meadow, it probably is not a zebra. And they will screw up for almost every white spot on an MRI scan. Very often it is due to small vessel disease, but small vessel disease or maybe let's say white spots on MRI scan. You have a differential diagnosis. And I think it's important to unravel this diagnosis of these different causes. And I think it seems very likely, with a couple of risk factors I just shared with you, it seems very likely that all of these risk factors will require different treatment. It's important to visit all of these. So if you would like to read more about small vessel disease and stroke by advice, I would like to draw your attention to this paper that just came out the other day. Access is QR code. Finally, I would like to thank my team, who is sitting in the sun, who even conference. I'm very happy it's raining and cloudy weather today. They're very dedicated to their whole here, and I would like to thank you for everything. Thank you.
Thank you. Yes, you are on time. I didn't check the time very much because I was so fascinated by your talk, but you made it on time, so we have time for questions. Yes,
Hi.
Please.
I'm Una Clancy from Edinburgh. Thanks for a very nice talk. And I really liked the image, the video where you had the person with serial imaging showing lots of tiny diffusion-weighted imaging hyperintensities. And you hypothesized after that a lot of that could be cardioembolic or hypoperfusion. But I would like to challenge that and say that if it is cardioembolic or hypoperfusion, then would you not expect to see at least some large vessel infarcts in such a patient, or watershed infarcts? And actually, do you not think that if it's a global brain disease affecting endothelial dysfunction, that you might see lots of small, tiny lesions in different hemispheres, and it is possible that lots of small infarcts are all due to an intrinsic small vessel dysfunction?
Yeah, I think your reasoning is valid, and I think because we lack policy, we can exclude the intrinsic factors because they will each kind of like is kind of a global forest of tiny micro parts, maybe even a large parts, but very well for people to excluding identifiers for the old source. And yeah, you cannot exclude something in the feelings going on below for isolation. Why there is one vessel and then another we're still at work.
Have you got questions? I have, yeah. Yeah.
Thank you.
Dr. Wardlow has a question.
Yeah, thanks very much. I wondered if in the Run DMC Intent study, which you mentioned, you've done any longer-term follow-up to see if underlying causes have emerged that may not have been so apparent at the time, and and so what were they, and or did you find any other underlying causes at the time?
Well, as part of another study, we're following again a large part of our Run DMC population, and they were part of this.
Next time. Thank you so much. We have to move on. Very good presentation.
Okay, so next we have Ana Verdelo, who's from Lisbon in Portugal, and is going to talk about cognitive and neuropsychological trajectories of patients with small vessel disease. Very important topic. So, thank you.